Hello, everyone. My name is Agnieszka McCord. I'm the Program Manager for the Prescription Overdose Prevention Program at the University of North Carolina Chapel Hill Injury Prevention Research Center. And I'd like to welcome you to today's webinar on the lessons we've learned so far from implementing Project Lazarus. Before we get into the full program, we'd like to begin with a few instructions from our hosts at the Children's Safety Network.
Great, thank you. So there are two options to hear today's audio. You can either listen through your computer speakers or you can call into our phone line at 866-835-7973. If you're participating via phone, please mute your computer speakers to eliminate echo. Phone lines will be muted during the presentation to eliminate background noise. If you have any questions or technical issues at any time, you can type those into the Q&A box on the bottom left. After the presentation, we will pause for the presenters to answer your questions. A PDF of the slides is available in the file share pod on the left. This webinar is also being recorded and archived and will be sent out to all registrants after the session. Back to you.
Thank you, Rebecca. Today we'll focus on many of the top-down or intervention-based components of the Project Lazarus model. Needless to say, neither the webinar series nor the implementation of Project Lazarus across North Carolina would have been possible without the support of our hosts and sponsors. We are grateful. However, it is important to note that while our sponsors have made all of this possible, none of the findings of our speakers today nor the conclusions drawn from the webinar participants during the discussion represent the official policies of the Centers for Disease Control Prevention nor our other sponsors. Even with this disclaimer, we hope that the presentations today will generate considerable discussion from our listeners at the end of the webinar. Should there be more questions than can be discussed before we close, at 3:30, we will include them and our responses in a white paper that will be released shortly. We'll begin today with introductory remarks by our science advisor from the CDC, Dr. Karen Mack. Dr. Mack?
Good afternoon, everyone. First of all, I would like to offer my thanks to all the staff involved in the CDC-funded project, the evaluation of a community-based initiative to prevent opioid overdose. Problematic prescribing practices are leading contributors to the prescription drug overdose epidemic. Safe and informed prescribing practices and instituting sensible prescribing guidelines can help stop it. Use of state prescription drug monitoring programs gives healthcare providers information to improve patient safety and protect patients. At the same time, they preserve patient access to safe and effective pain treatment. Cities and states across the country have taken steps to improve painkiller prescribing and prevent prescription misuse, abuse, and overdose. These efforts include regulating pain clinics, using systems to identify fraudulent prescriptions, and improving access to naloxone. CDC is conducting research to understand the circumstances and risk factors for overdose, and we are supporting states to ramp up their efforts in reducing overdoses. States are crucial players in reversing the epidemic. The recent CDC FOA, Prescription Drug Overdose Prevention for States, provides state support and resources to build robust prevention programs. Two required strategies were, 1, to enhance and maximize a state PDMP, and 2, implement community or insurer health system interventions aimed at preventing prescription drug overdose and abuse. Two optional strategies were to conduct policy evaluations and/or develop and implement rapid response projects. Existing evidence, though sparse, indicates the potential of PDMPs to identify patients at high risk of overdose and to impact key prescribing behaviors. Implementing community intervention targets enhancing and empowering community-level prevention. For community interventions, activities could include deploying and coordinating intensive prevention efforts in high-burden communities and working with local health departments to disseminate analyses of prescribing and overdose trends. Insurer health system interventions could include drug utilization review, prior authorization, quantity limits, and coordinated care. Understanding the effectiveness of prescription drug overdose policies is crucial. evaluation of laws, policies, or regulations designed to prevent prescription drug overuse, misuse, abuse, and overdose are important. As you know, the prescription drug epidemic is fast-moving. States have had the opportunity to break new ground in addressing the epidemic. For example, states could use restricted recipient programs to build a new syndromic surveillance system or test a new communication campaign. States need to be nimble and working collaboratively with other states as well as CDC to identify priority actions to use in responding to emerging public health threats. I'd like to thank everyone for participating in the webinar today. Curtailing this epidemic will take the effort of all of us, and I want to thank you for this work for your work in this area. Our next speaker is Dr. Ringwalt from the UNC Injury Prevention Research Center, who serves as the center's principal investigator for the evaluation of Project Lazarus. Dr. Ringwalt?
Good afternoon, and to those of you who joined us last month for our initial webinar in this two-part series, welcome back. As you will remember, we talked about lessons we have learned from implementing the community-based, or bottom-up, aspect of Project Lazarus. Today, we will switch gears and talk about lessons we have learned related to the provider-oriented, or top-down, aspects of the program. But before we get started on that, here's a recap of some of the lessons we shared with you in May. First, and perhaps foremost, we learned that to bring about change at the community level, we would need to raise the community's awareness of the need to implement an array of opioid overdose prevention strategies and to find, train, and support key stakeholders within the context of community coalitions that are dedicated to that purpose. We also learned how important it was to develop a strong relationship with each county's Department of Health as the logical lead partner in developing and facilitating these coalitions. But coalitions typically comprise very busy people, and to accomplish the challenging job facing them requires financial support, technical assistance, and other resources such as tools to develop public awareness and policies and protocols for which to serve as an effective catalyst for change. Thus, with the support of our funders, our partner, Community Care of North Carolina, which is the state's Medicaid authority, is supporting regional consultants who provide assistance in building capacity for coalition functioning, strategic planning, templates for policies and protocols, examples from other communities, and data to assist with planning and evaluation. This formal structure, we believe, is essential to the success of our efforts to roll out Project Lazarus across the state's 100 counties. We should stress again that the key function of a coalition is to serve as a catalyst for social change, not a direct service provider. In that regard, it can be very helpful to identify people in the community whose lives have been directly touched by the epidemic of opioid overdose and whose stories are likely to be compelling and powerful. These stories are based on data. Their acquisition and analysis are often some of the most challenging core functions in Project Lazarus, as data services serve as both the mechanism through which community awareness is heightened and support the success of the program as evaluated. The final thing I would like to say in this brief summary of last month's webinar is the importance of efforts to ensure the sustainability of the work of the Community Coalition through identifying and supporting potential leadership, assisting it with securing continued funding, and providing strategies to keep the good work going even in the absence of financial support. Today, our speakers will talk to us about the lessons they have learned from selecting and implementing many of the top-down interventions in the spokes of the Project Lazarus model. Each of these 7 categories contain a smorgasbord of evidence-based interventions from which communities can choose. Some communities have chosen to work on all 7 categories, selecting 1 or 2 interventions in each. Others have only been ready to implement 1 or 2 categories. We'll begin with a presentation by Fred Brayson, the CEO of Project Lazarus, who will describe some of the lessons that he and the program have learned in designing and implementing community education and pain patient support. Fred, over to you.
Thank you, Dr. Ringwalt, and again, welcome everybody, and pleased that you're able to join us, and I appreciate those of you who I've actually met face-to-face since the last webinar. And today we'll cover a couple of different items regarding the spokes, of the model. But again, want to thank the CDC and Dr. Frieden, the Children's Safety Network, SAVER, and IFRIC for bringing this about. This crisis that the public health is in, the slide that you're viewing sort of brings about the balanced, comprehensive approach that meets the needs and brings about the change in the outcomes that we all desire and seek. We want to make sure that we do prevent prescription opioid and heroin overdoses, benzodiazepine and combination of those, opiate poisonings, heroin. We also wanted to ensure appropriate and accessible patient care, so we continue to present responsible pain management, while at the same time we're promoting substance use treatment and support services within our communities to meet those that have developed issues over time from use, in order to treat the disease of substance use disorder and addiction. And it's very crucial and important for that balance to be not only built, but to be maintained. And as I've shared frequently in here before, we can not only look at overdose numbers from a national or state global level, but continually obtain and review local level data, as it is important to further the investigation to determine the factors that have led up to an overdose. We've always asked the questions of the who, the what, the where, the when, the how, and the why did that occur. And as we look at that, we find that we have had, patients who have slipped into respiratory depression from taking the amount of opioids prescribed, but it overwhelmed their system, or they simply did overuse, or unfortunately added something to it. We've had loss of life due to family and friends sharing medication, which is a frequent practice within our neighborhoods and communities. We lost community members, especially toddlers, to accidental ingestion due to the amount of prescription medications that have been dispensed that are in nearly everyone's homes. There are individuals who just want to have a good time every now and then. I call them the recreational user, and unfortunately when you add the medications and other drugs into the usual, which was the alcohol, marijuana, and the like, the danger and the risk of overdose has escalated. And of course there are those who have slipped into disease of addiction to opioids and other substances, and may or may not be in treatment, may or may not be in recovery. But this shows us that in every community, every population group, every age needs to be reached. It's crucial with the appropriate messaging to bring about the behavioral changes and practices surrounding medications and ensuring safety across the board. That's why it is important to address this from a public health perspective, so that we are reaching everybody, regardless of where they are in life, what their circumstances are, and understanding the appropriateness and the behaviors surrounding medication. Next slide. As we have seen before, the Project Lazarus model covers many different areas. I'm sure you'll see it even again in today's webinar, with a public health approach of hub and spokes. I'll be focusing today on community education and providing services and support to people who have pain issues, whether acute and or chronic, and the possible scenarios of their lives, and then changing it from, to a public health approach. Next slide. Community education is crucial. Again, that's reaching everybody at every age regarding their perceptions and behaviors or misconceptions, whatever that might be, regarding any medication that sits in anybody's home. We learned early on in our work that to engage the general public, we had to connect the dots in their lives. In other words, they had to realize where they fit, what part do they play, what role do they play, or what changes can they make. When we first started the approach in North Carolina, we had to do a lot of awareness building about the misuse and abuse of prescription pain medication. Fortunately or unfortunately, as you may look at that today, that the awareness is not so much necessary as crucial as the education. And as we began working with each specific population group or community sector, we had to frame our messages to show them why they need to be involved, what they need to know, and then what they could do. Then we started to provide that information so that they knew that there was something that could be done, that they could do, that they could implement. They could each become connected themselves and actually take an action from the knowledge. This brings about a change, whether it's a behavior, such as always locking up your medications, whether it's ensuring that they or their loved ones and others take medication correctly, that they begin to store their medication securely, that they dispose of it properly, and of course, never share. We had created a simple set of actions that could be applied to every single age level. But the simple fact is, if it's your prescription, you take it correctly. If it's not, you don't take it. And if you recall from the hub and spokes model, data was used to really drive the messaging and the reality of the situation within our communities. It is important to obtain and interpret provided data to make it understandable to the community. We often need to translate the statistics and communicate its relevance for the general public within every segment of a community. Here's an example of a lesson learned. As we began to provide prescribing data to local communities and they saw that they were above the state average, there was a kind of knee-jerk reaction that we have to get medical providers to prescribe less pain medication. Sometimes the consensus was there needed to be a decrease anywhere from 10 to 15 to 25, 30 to as much as 40% less than what the average was in that county. It was clear from the onset that some communities are going to have higher and some are going to have lower prescribing rates than the state average. That's the way statistics work. And we were not surprised that the prescribing rates in Wilkes County were and continue to be higher than state average, even though the rates have decreased over the past 5 years. There is no one optimal rate. We just want to ensure appropriate prescribing and ensure that there are safety mechanisms and education to that patient is served and protected. With data, we can drive change in practice and in policy and guidelines surrounding it and take a more comprehensive community sector public health approach to the issue, which now we have learned that Stanford in its research has given it a name that we didn't begin with but realized that we have done. And they put a label on it, a name, and it is collective impact in bringing about large-scale social change that requires broad cross-sector coordination, yet the social sector, the community sector, remains focused on the isolated intervention of individual organizations within its own sphere of influence. This is how we are approaching this. And community education obviously has multiple spheres, multiple sectors, so that we have to bring it to each one specifically as to who they are, what they can do, and then what needs to be done. Changing community norms in the next slide is complex. With this slide, it illustrates it is to reach the community. We have to work with both the individual and the environmental situation. With every single community, every individual has different biological factors, different psychosocial factors, and spiritual factors. All of those have to be addressed. Each have different factors within their lives, and so we can change the community ultimately, we can change the individual. In doing that, we certainly had to address each community sector with the appropriate knowledge and education and understanding so that they could be put into new best practice. But again, keeping it within their sphere of influence. The schools working with their population groups, the human services with those that they touch, the civic and youth groups in the senior services who they touch, our faith community, which is obviously multifaceted. Villages that change and reinforce the individual and bring about long-term change, and that is what we're seeking as we do community work and have been doing here in North Carolina. Next slide is the purpose of this webinar is to point out our lessons learned about the good, the bad, and the ugly of what's being done and has been done. Every community teaches us something new because every community is different. They all have different factors that they have to address, and something better, a different way of leveraging within our population groups. We learned early on that the lack of knowledge and understanding hinder appropriate and wise decision making. Whether it is an individual, a sector, or the entire community that hinders progress, increasing knowledge and understanding are critical. Myths create stigmas and prejudices, especially around substance use disorder. Yesterday's attitudes unfortunately influence the today's, often in a negative way. That remains the biggest obstacle to reaching those who need help and care. Many communities have often viewed any kind of drug-related issue as a personal situation due to some moral failure or as a behavioral issue and not as a public health concern. It is very important to draw the connections to show that the safer prescribing of pain medicine and overdose prevention are a broad-based public health concern, and remedies can be fashioned in response accordingly. The challenge is that many communities lack the organizational structure, as we found here, and secondly, lack the will or the desire to identify and collaborate with the multiple players that are necessary to address the complexities of this drug epidemic. In part, that's due to many different levels of resources and materials, whether it's personnel, money, and so forth, in different organizations within the community. But there again, every community, every organization, every sector is entirely different and has to be individually approached just as we would individualize any kind of treatment or care for a person. And the next slide, as it moves forward, Project Lazarus has profited by creating solutions to the lessons we've learned along the way. Many questions arose early on as we started a statewide initiative. Where do we begin? From a data perspective, we originally assumed that we could just begin with the worst of the worst communities. We realized early on that's not necessarily the case. We moved where the energy was, where there was someone or a community group or organization that was already active within the community or seeking to become active. We realized that by investing in that energy, that leadership, we had a higher rate of success of implementation, quicker implementation, and longer-term sustainability. We learned that our best approach was to come in as an outside source for support with some money and materials and education. The community needed to pick it up and move forward. We found that by investing in them and enabling them to work independently and not to rely so much on us and others from the outside would result in sustainability from within for that long-term change that we are seeking. Next slide. After another intervention in the Project Lazarus model is setting up the mechanisms to support people living with pain. As I mentioned early on, we want to make sure we strike a balance. It is important to address the misuse and abuse of prescription pain medication, but it's equally as important that we have accessible care, appropriate care, safe care with the medications that are necessary for individuals to function. Strategies need to be put in place to medicate and keep their pain at a significant lower level in order for them to maintain the life that they have been accustomed and desire to do. It's meeting those individuals where they are and helping them across the board. As in this slide, this is our friend Diana. She's been in our original video, a Wilkes County Project Lazarus spokesperson who from the outset helped get the right people talking to the right people. I firmly believe in a peer-to-peer based approach. I truly believe that those that have walked the walk know the talk and the circumstances surrounding those who live with pain, those who have a mutual support system, can surely make a difference and can lead people into better care, initiate better practices, and help the entire community. Studies have shown us over and over again how peer-to-peer based support networks work. A critical lesson learned is that a support network for those with chronic pain are sorely lacking within almost every community. Looking into the entirety of a person, cultural and environmental, or other physical well-being issues is important and necessary. Pain patient support also requires looking at the different therapies other than pain medication that can help abate pain and help redirect. These alternative approaches include physical therapy, music, breathing, wellness, nutrition, exercise, prayer, meditation, yoga, acupuncture, and in short, there are many alternatives and additions to pain medication that unfortunately are not readily available or in some cases not even acceptable, especially in our rural communities. An important lesson from Project Lazarus is the critical need to include pain patient, the person with pain and their support, as one of the stated intervention categories. We've done that through operating with the Community Care Network, North Carolina's Medicaid infrastructure, by working with the care managers in the Chronic Pain Initiative who do address the biopsychosocial aspects of every patient in their domain. Implementation is varied as regions are different. Additionally, I firmly believe that integrating behavioral health into the general primary care services around communities is a key and important factor that needs to be done because of the lack of resources and the lack of referral mechanism. The practitioners are prescribing and treating pain, but by having behavioral health services in the house, they are looking at the individual so that the full biopsychosocial aspect is addressed. We've also learned that a key factor to pain patient support requires home health services, bringing the eyes and the ears from the home back to the practitioner. We realize home health can be engaged in every scenario. It can't be engaged in every scenario, but it can in some. I'm encouraging the practicing community to make sure that they include some aspect of home health care as it can provide home education, promote overdose awareness, and reinforce the strategies that medicine needs to be taken correctly, stored securely, disposed properly, and never shared. And when we start talking about overdose and respiratory depression, we realize that that person, that nurse, that caregiver in that home can play a crucial role in safety and the provision and the understanding of the use of naloxone. As I wrap this up, again, I thank you for your time and your participation and welcome any of your questions and look forward to meeting many of you on the road as we endeavor to work together to bring about a change in all of our communities. And now I'd like to introduce Dr. Sarah McEwen, the Executive Director of the Government Institute on Substance Abuse in North Carolina, who has been instrumental in creating the medical care provider education component of the Project Lazarus model and ensuring that, from that practitioner perspective, that appropriate and good, responsible pain management and prescribing is done. Thank you. Welcome, Sarah.
Thank you, Fred. Good afternoon, and thank you for inviting me. As Fred said, I'm with the Governor's Institute, and we've been providing training and workforce development for physicians and other healthcare providers for about 20 years. And in fact, in 2009 to 11, we implemented the Safer Opioid Prescribing Project, also for KP Reynolds Charitable Trust. Worked with Fred on that as well, and it had a clinical and community component, much like Project Lazarus does. We well know that behavior change, including prescribing, is extraordinarily difficult, and it needs technical assistance, including mentoring, skills development, and most of all, systems designed to be effective. So at the Governor's Institute, we have strong relationships with CCNC, the primary care community, the behavioral health community, the professional boards, state and federal agencies. So we were the obvious choice to take on the clinical training component. So what was the training? The core training, there were 40 of them. They were 3-hour trainings across the state. 20 were Category 1 CME through the North Carolina Academy of Family Physicians, and 20 were supported by Pfizer, so those were non-CME. The trainings were essentially identical. It's just when you would get credit and when you would not. We tailored them to local conditions. Whenever possible, we had a local person, whether it's the public health director, CPI coordinator, somebody else from the community or the network, to present some statistics and epidemiology for that specific location. We had a 2-person team for all of the trainings, and our primary target was prescribers and pharmacists. But we also wanted other partners to attend, so linkages between primary care and specialty behavioral health and pain management could be established. And because we know docs and seats doesn't do a lot of good, we really focused on skills and tools to aid implementation. So on the next slide shows that we had, for the core presentations, we had 2 presenters. The main presenter was any one of several different specialties, but they all had addiction medicine expertise. The second trainer was somebody was a regional pain management consultant. So we tried to find people as we went across the state who were local, so that when we wanted to identify local and referral options, because part of because after the training was over, we were going to have ongoing technical assistance, and we made these presenters, particularly the pain management specialists, available to the networks for technical assistance. And the Pain Society of the Carolinas was really helpful in vetting the potential pain specialist mentors. As I mentioned, we also invited local behavioral health resources. Many of these communities did not know about or interact with them. And since the project was implemented through CCNC, the network served as the conveners, as they were the ones with the primary relationships with the practices. So here's a little bit about the core content. The training itself consisted of an overview of chronic pain, and that was based on Pfizer's pain narrative. It covered assessment and risk stratification, framing opioids as a time-limited trial, monitoring and intervening with aberrant behaviors. And we felt it was important to communicate the need for careful screening, monitoring, and extreme vigilance, but without scaring docs off who may decide to not prescribe at all. That has happened in some other states, and we wanted to avoid that in North Carolina. We also felt that it was important to address stigma and preconceived notions about so-called doctor shoppers. So we spent some time differentiating addiction and physical dependence, pseudo-addiction, chemical coping, the different presentations of aberrant behaviors. And the concepts were modeled and practiced throughout training via an ongoing case discussion between the core presenter, the pain specialist, and the audience. And really, cognitive buy-in was not all that difficult. It's really implementation that's the bigger challenge. So on the next slide, you'll see that therefore we had significant focus on clinically relevant tools to facilitate implementation. This included 3 toolkits, one for primary care, one for emergency departments, and one for care managers. And we focused on using the controlled substance reporting system. We worked with professional boards to facilitate registration, provided sample treatment agreements, sample ED policies, provided screening tools, information about naloxone and buprenorphine, and guidance on urine drug screening. So a little more in the toolkits. I've listed some of the components of the two clinical toolkits, one being for primary care, one being for emergency departments, and there's a third one on care management, which I have not listed. But you can see there's a lot of emphasis on tools and resources, again, because we know that educating doctors in evening trainings doesn't move the needle a bit. So I think that the Project Lazarus Advisory Work Group was really important. Multiple stakeholders were brought to the table from the get-go, and I think this was pivotal to success. Included from the start were the listed boards, societies, provider organizations, and other agencies and associations across the state, and there are probably others that I failed to mention. But because it was so inclusive, we really had no one left to launch grenades and really had a very concerted group going forward. So of course, there were lots of challenges. Some have been resolved, some have not. The lessons learned fall into these general categories, that the degree and nature of local involvement very much dictates the approach, that you need to have continuous content modification and supply tools and ancillary materials, that you really need to be flexible with technical assistance because that is very local. Partnering with Pfizer has advantages, but it also presented some challenges. Engaging EDs when it was an issue, in fact a big one. And there are also geographic challenges of being a largely rural state with uneven access to behavioral health and pain expertise, especially pain expertise that accepts Medicaid in the rural areas. So first I'll start with the degree of local involvement, which very much determined how to approach a community and how to follow up. Optimally, Project Lazarus would be simultaneously underway in the broader community in the ways that Fred just talked about. It's best if the clinical training program is introduced by a local person, usually a CPI or behavioral health coordinator, with the idea that they would present why this is important in our community and that the presenters of the project are here to help us with our identified problem. We thought it important that it be framed that way, that the program and project can help physicians work effectively with very complicated and challenging patients, that it's a solution, not another project to put on the agenda. And the networking outcome was also very important. We wanted to facilitate local partnerships with pain and substance abuse expertise that would endure beyond the grant period. And this has worked well in some places, less well in others, but overall has been underutilized. So as far as content refinements, we very much wanted to have a degree of standardization for the 40 trainings because it's a statewide CCNC project. But it was also, of great importance to the funder that through Project Lazarus we combined myriad chronic pain projects into a single comprehensive initiative. But that being said, some updates were made along the way to accommodate changes in the environment, and we largely did that by way of adding ancillary materials. So here are some of the major tools and ancillary materials that we included. There was an updated position statement from the North Carolina Medical Board based on the Federation of State Medical Boards. There were upgrades to the CSRS registration and usage, so we increased guidance around that. The changing landscape around naloxone and its availability, the Good Samaritan Law, the CCNC Pregnancy Medical Homes Development of Care Pathway and Guidelines for Opioids in Pregnancy. We developed some video modules on urine drug screening. There's another one planned for how to best use CSRS information. And those are just some of the highlights. So partnering with Pfizer, it had its challenges. They were one of the stakeholders on the advisory group, and they provided support for 20 training, which enabled us to have 40 trainings all told. So, and they also were responsible for the pain narrative for primary care, which served as the basis for the first part of the core training. But there were challenges. Their trainings were non-CME, so they were in less demand and less well attended. It also limited our speakers bureau, and there was, unfortuitously, a corporate reorg, which meant that the drug reps assisting with recruitment were brand new to their areas and really didn't have any context. So now we'll move on to emergency departments. We knew this aspect of the problem was going to be difficult, but even so, we underestimated it. We really were not at all successful in getting ED docs to attend the combined evening trainings, and we were really only minimally successful with EDs separately. There were the problems of time, shift work, culture. There was also more of a disconnect between EDs and CCNC than we had anticipated. We assumed the networks would have closer ties than they do. And that's just the training barriers. Of course, there were also implementation barriers. The major ones including time, workflow, emergency department physicians who work in multiple hospitals which have different ED policies, protocols, access to the CSRS. There's also the issue of Press-Ganey patient satisfaction scores that can have bearing on hospital and physician compensation. The best ED engagement strategy seemed to be around naloxone and working with EMS and law enforcement around that. So all that being said, we did have some wins. CSRS modifications were made, and they were particularly helpful to EDs. Several major hospital systems came on board and adopted system-wide policies for their EDs, and this was obviously a higher yield approach than working with individual hospitals, but there are more hospital systems to engage. And in all honesty, most of the hospital engagement arose out of the community campaigns rather than the clinical trainings. While we invited hospitals, CEOs, COOs, and other admin to attend the trainings were very prescriber and pharmacist-focused by intent. We thought it better to not dilute the content so we wouldn't lose our primary audience. There was initial discomfort on the part of hospitals which implemented restrictive prescribing policies and then had poor patient satisfaction Press-Ganey scores. Although we saw this as a very significant potential barrier, at least anecdotally, it proved to be less pivotal than anticipated. The take-home seems to be that hospitals need to be willing to accept initially poor scores. At least in our experience in North Carolina, they tend to right themselves after a specific hospital ED establishes a no opioid policy and the word gets out. So ED barriers do remain, time and workflow being the biggest impediments. In truth, emergency departments are not and never will be ideal venues for relatively complicated pain and behavioral health assessments. Besides time and workflow, there is the real or perceived lack of access to community mental health, substance abuse, and pain expertise. This lack of resources is very real in some communities, especially in rural areas. In other areas, there were, in fact, resources, but they were not being utilized. And part of the project was to facilitate these linkages. We have a lot more work to do in this regard. And then, as mentioned before, not all hospitals or hospital systems are on board yet. So there were several catalysts that helped us out. As mentioned, the Federation of State Medical Boards and the North Carolina Medical Board issued new recommendations in 2014. North Carolina's Mountain Area AHEC got a large CMS Innovations grant to do work in the opioid overdose arena, and we partnered with them. There was enabling state legislation, the work of the Harm Reduction Coalition, the aforementioned partnerships, and of course the many other opioid overdose initiatives like REMS that we were able to tap into. So for next steps, The clinical component ends July 31st, but before then we will finish work on the online training. It's going to be a 3-module, 3-hour CME training, and our hope is that the major malpractice carriers will award risk reduction points for physicians who do the online training. This has been implemented quite successfully in Colorado. And we will continue to provide training, facilitate linkages, make upgrades, both to improve the safety and effectiveness of chronic pain and better preventing and identifying substance misuse. And CCMC will continue to develop disease-specific protocols like the one developed for fibromyalgia. So I think my time is up, so I'll stop now. Thank you for your attention. I will now introduce our next speaker, who is Tessie Castillo. She's the Communications and Advocacy Coordinator with the NC Harm Reduction Coalition.
Thank you. I'd like to talk a little bit about the harm reduction spoke of Project Lazarus and how it's a good model to illustrate lessons that we can learn when working with multi-partner collaboration, especially with particularly challenging components of overdose prevention. North Carolina Harm Reduction Coalition is a statewide nonprofit that's dedicated to reducing the negative consequences of drug use, including drug overdose prevention. We're not a part of Project Lazarus. We're a separate organization, but we do collaborate since we have the same goals of reducing opiate overdose in the state. We work with different populations. Project Lazarus, as you know, works through the co-prescribing medical model. North Carolina Harm Reduction distributes naloxone directly to people at risk for overdose on the street level, such as people who are actively using drugs. I want to take a look at the overlap between the programs. So some of the populations to whom naloxone is distributed are unique to North Carolina Harm Reduction Coalition, such as the heroin-using population, people who generally have no interaction with the medical community, whereas Project Lazarus works a lot with the population who's prescribed opioids for pain management from medical care providers and may not seek opioids from any other sources. But there are populations where there's crossover, where both Project Lazarus and NCHRC work, such as, for example, people who use pharmaceutical opioids from illicit and illicit sources, and people who may be there to witness an overdose and can be trained on how to recognize one and reverse it. Also, one area in which NCHRC and Project Lazarus collaborates is identification and training of community-based distributors, again, in each of our separate or mutual spheres of interest. There is an overlap in this area. For example, Project Lazarus works primarily with medical providers who treat patients with chronic pain, also with community-based physicians who can provide standing orders that are required for North Carolina Harm Reduction Coalition volunteers to distribute naloxone to the drug user community. Both North Carolina Harm Reduction and Project Lazarus have worked separately and together to convince law enforcement agencies and first responders about the principles of harm reduction and its applicability and the appropriateness of responding to overdose as a medical emergency, focusing on saving the person's life as opposed to focusing primarily on diversion, control, or arrest. Definitely distributing naloxone to patients in pharmacies has also been a joint venture between Project Lazarus and the North Carolina Harm Reduction Coalition as well. As far as lessons learned, one major lesson is that there needs to be a legal framework in order to have naloxone distribution. If the laws are not in place that allow it, it really becomes difficult to run a program. So states that have laws that allow for standing order distribution or naloxone distribution are very helpful. Another lesson is that these laws can be passed in any climate, meaning that originally when North Carolina Harm Reduction and Project Lazarus decided to pursue laws regarding naloxone access in North Carolina, we were the first state in the country actually to do so with the current political climate, and a lot of people said that they didn't think it could be done. but we proved that it could be done. And since then, other states have, with similar political climates, have also passed naloxone legislation, such as Georgia and South Carolina, and a number of other states in the region. A little bit about the 911 Good Samaritan law. So that law became effective April 9, 2013. It provides limited criminal immunity for possession of small amounts of drugs, drug paraphernalia, or underage drinking to a person who experiences an overdose or seeks medical assistance for someone experiencing an overdose. Additionally, it provides criminal immunity to anyone who administers naloxone in good faith and to medical providers who prescribe it. And it allows prescribers to prescribe naloxone via standing order. Standing order refers to the practice of issuing a prescription to people who meet certain characteristics, such as being at risk for opiate overdose, as opposed to writing a prescription for a single patient by name. As the Project Lazarus is rolling out and we're getting providers to warm up to the idea of co-prescribing naloxone, we recognized that we needed to do something to address the immediate problem of people dying. So we launched a naloxone distribution program back in August of 2013. Since then, we've distributed well over 11,000 kits across the state in North Carolina through a network of staff members and volunteers and contractors. The reported number of people who've successfully used the kits to reverse an opiate drug overdose is actually 604. It's gone up since these slides were turned in last week. So it's a very successful program. Some lessons that we have learned from that are that, for one, it doesn't really matter what type of naloxone you use. We found people open to intramuscular forms, intranasal forms, FZO. They all work very well, and it doesn't really seem to make that much of a difference which version you're offering under most circumstances. Another lesson that we've learned is within the state and across the country about documenting the results of the reversals. This is a problem that all naloxone distribution programs have, is how do you know if the kits were used? How do you receive report backs about that? North Carolina Harm Reduction has been one of the most successful organizations as far as getting people to actually report that they use the kits. There is a website through the Injury Prevention Research Center, naloxonesave.org, and certainly Project Lazarus. North Carolina Harm Reduction label every kit that's distributed with the phone number or an email address or website where people can report that it was used. But that's not used very often, we're finding. The most effective way to get kits reported is word of mouth back to the volunteers, usually the same person who gave the person the kit. So for example, just looking briefly at these three places where the rescue sites where we've gotten the most reports of reversal, that doesn't necessarily mean that those sites have the most overdoses or that we've distributed the most number of kits, but rather that we're the most effective at utilizing those sites as to receive reports. So for example, in Asheville, we hand out our kits mostly in methadone clinics. And since methadone clinics do same patients every day, when we go back to the methadone clinics, we're able to see the same people we already gave the kits to and ask them, did you use it? And that's how we get reports from that population. In Greensboro and High Point, we distribute primarily through an active drug user network with peers, as Fred was talking about earlier. And the peers, since they're known in the community and they're trusted in the community, and they're the ones who hand out the kits, they are also the ones who get that phone call when somebody actually uses the kit. Another lesson that we've learned is that it's important to involve law enforcement in the overdose prevention. North Carolina Harm Reduction and Project Lazarus have trained jointly about 15 law enforcement departments, which has resulted in an additional 9 overdose reversals throughout the state. We did a survey, North Carolina Harm Reduction, of law enforcement officers. There's a common perception that law enforcement would not want to participate in a naloxone distribution program. That's actually incorrect. So we're finding that 90% of law enforcement officers actually do want to participate. As far as best practices is concerned, definitely standing orders. I talked about that before. When you can get a standing order written so that you can distribute naloxone through community organizations or health departments, it's just a lot more effective than going person by person as far as it being quick. Mobility is also really important. So we've seen some fixed site locations where, like say at a health department, where people have to go to the health department to request naloxone. It's not as effective as having a mobile outreach worker who goes out into the community and distributes the kits that way. In High Point, we actually had an outreach worker and a fixed site running at the same time. And at the fixed site, we distributed 5 kits, and with the mobile worker, we distributed 235 during the same time frame. And also, as I mentioned before, distributing through peer networks. If you get people who understand drugs, who use drugs or used to use drugs, to distribute it to their peers, it's much more effective. Some challenges that we've run into are funding, obviously. That's one way that everybody runs into. One thing that we've done is that we've utilized intramuscular kits primarily because they're a lot cheaper than the other forms of naloxone, and we really stripped down the kits so that they're as simple and as cost-effective as possible. Seeking small city or county level grants, we've shown has been very effective as far as funding and taking advantage of free or reduced prices from pharmaceutical companies. Another challenge is myths about naloxone. You get a lot of people saying, well, doesn't this encourage drug use, which is not true, and it's just a question of educating people usually to allow them to really understand what naloxone is and what it does, and also overcoming some fears about syringes and allowing people to embrace intramuscular naloxone. Another challenge is reaching across the state, since we only have 3 staff members, and we were able to do that through a network of over 100 volunteers.
Donnie Bonnell, I think you're up next.
Sure. The Diversion Environmental Crimes Unit with the State Bureau of Investigation is primarily tasked with investigating the diversion of prescription drugs by licensed healthcare professionals and others involved in the healthcare registrant field. We do large-scale multi-jurisdictional prescription fraud cases, which is what we spend the majority of our time on, suspicious deaths in healthcare facilities, and overdose-related homicides. We provide training in diversion investigations, prescription drug abuse awareness, and environmental crimes investigations. We also work all state and federal state statutes involving Clean Water Acts and other violations of the environment. Right now our unit is consisted of 1 special agent in charge, which I'm lucky enough to be, 2 assistant supervisors, 11 agents, and an admin assistant, and they cover all 100 counties across the state. I've had the pleasure of being affiliated with Project Lazarus for the past 3 years. Since then, we have supported each other on several issues to include medicine take-back programs, the funding and placement of drop boxes, and now the prevention of opioid overdoses through the naloxone initiative. A lesson learned from this collaboration is that even with less than desirable staffing and funding, partnering with agencies and programs like Project Lazarus, Community Care of North Carolina, and the Injury Branch within the North Carolina Division of Public Health extends my unit's capacity to reduce the impact of illicit controlled substances within the state. In an effort to help combat the abuse and diversion of prescription drugs in the state, our unit implemented a training program for local, state, and federal officers. Over time, we have tailored the program to reach other communities, such as medical professionals and our youth. One of our earliest updates was the approach to the issue of how to prevent overdoses. While reducing the access to illegitimate prescription drugs was an obvious step, our data suggested that most drugs are obtained for free from friends or relatives or from a doctor. We felt it was important to provide information to our officers as part of continuing education to the community at large in community forums on what behaviors increased a person's chance of overdosing, and in turn what steps should be taken when someone was possibly suffering from an overdose. These teaching points have been well received by both law enforcement and the public. Early on, after seeing the success of Project Lazarus and being aware of the work of the Harm Reduction Coalition, I decided that the SBI needed to be in the forefront of the state's law enforcement participation in the naloxone program. There were some obstacles involved during the process. The two most pronounced included the liability of providing medical treatment without being requested and the cost of acquiring the naloxone kits. With the help of Project Lazarus, the Harm Reduction Coalition, we were able to provide the Bureau management team with pre-existing policies that were being used by other law enforcement agencies. We were able to tailor these policies to fit our particular needs. As for the cost of the program, we were able to have the initial kits donated. Our management has decided that we will be able to appropriate the funds for the follow-on or replacement kits through general funds or drug seizure assets. We also used the positive press that came from the saves mentioned earlier, enacted by other departments to promote the program to management. We stressed to all involved that the naloxone program would be a life-saving tool to a wide variety of people. Not only would it save the chronic drug abuser, but having our SBI agents carry naloxone means that they can potentially save the lives of the elderly who took the wrong medication or the young people who accidentally ingested these medications. In my unit, we believe that all lives are precious. I would add that by working with the SBI, this has caused several other large state and local departments to inquire with the Bureau about what steps should be taken to carry these kits. Operation Medicine Drop, housed in the North Carolina Department of Insurance, is a partnership of Safe Kids North Carolina, North Carolina State Bureau of Investigation, Community Anti-Drug Coalitions of North Carolina, Project Lazarus, and local law enforcement agencies working together to encourage the public to safely dispose of unused, unwanted, and expired medications. Since 2010, Operation Medicine Drop has collected nearly 70 million dosage units at more than 1,600 events held in most of the state's 100 counties. In North Carolina, pills are collected during biannual pill take-backs and from pill drop boxes. Pill take-back days and drop boxes are successful in removing excess drugs that can become the basis for diversion. However, both have come with challenges. The primary challenges are administration, funding, and manpower. Until recently, the pill take-back days have been supervised in the field by the DEA in the fall and by the SBI in the spring. As a more permanent solution to disposing of unwanted, unused, and expired prescription drugs, Operation Medicine Drop and Project Lazarus has acquired and dispensed over 100 secure pill drop boxes for installation at local police departments. DEA will no longer sponsor pill take-back days. The most important ramification is that they will no longer absorb the cost of transporting collected medications to a facility which can incinerate them. It is unclear whether there will be pill take-back days this fall in North Carolina. The SBI will continue to support local law enforcement agencies and conduct a pill take-back day in the spring as funding allows. Another lesson learned from the pill take-back days is that not only is sponsorship precarious, but so is identifying and maintaining an EPA-certified incineration facility. For many years, there were several such facilities in North Carolina. Several years ago, the number dropped to 1. Last year, the mid-state facility could no longer accept pill take-back shipments, and the DEA had to collect and transport the collected drugs to a facility in Alabama. After last year's fall pill take-back day, the DEA stepped out of the role of sponsoring these types of events because the U.S. Attorney General announced a new DEA regulation that now allows pharmacies, hospitals, clinics, and other authorized collectors to serve as authorized drop-off sites for unused prescription drugs. Under the new policy, long-term health care facilities will also be able to collect controlled substances turned in by residents of those facilities, and prescription drug users everywhere will have the permission to directly mail in their unused medications to authorized collectors. On paper, this sounds wonderful. Unfortunately, this may simply end up being another unfunded mandate that was written with the best of intentions. Few pharmacies or other authorized collectors to date have been willing to ante up the money to pay for the return of unused medications. Permanent pill drop boxes as an alternative to pill take-back days are now located in over 100 sites in North Carolina and as another case in point. The SBI worked with Operation Medicine Drop and Project Lazarus to have secure pill drop boxes installed in many police departments within the state. The most important lesson we have learned from law enforcement officers who maintain these pill drop boxes at local police stations: there is often an unexpected heavy time and manpower commitment to their maintenance that lacks financial support. In other communities, the law enforcement officers assigned to maintain the drop boxes are not those who made the decisions to install the boxes, and some feel collecting unwanted medication is not a police function. A common issue that we hear, however, is that agencies are extremely concerned with the cost of disposing the medication. This has caused some agencies to consider removing the boxes. Chapel Hill in North Carolina can serve as an example. The pill drop box was installed in the lobby of the town's police department well over a year ago. The box is used often enough so that it must be emptied at least every 2 weeks. At the end of the 2-week period, it takes 3 or 4 officers a minimum of 1.5 hours to complete the job. It is a labor-intensive process. The bag of medications is removed from the drop box and taken to a booking room on camera where the contents are spread out on a desk and sorted into 1 or 4 containers. Each bag is then weighed on a scale in yet another room and then taken to the evidence room where it is placed in a drum. Now that the drum is full, until last fall, all bag drugs were held on site until the fall when they were given to DEA for disposal on the pill take-back days. This is no longer an option. Until a disposal system is put into place, each additional bag that is collected will take up more and more of the limited evidence storage room space. This problem is being worked on, and I doubt very much that Chapel Hill is unique. We have not identified all the problems, never mind solve them. Sometimes it is our success that leads to the most impressive lessons learned. Diversion control is an integral part of overdose prevention, and we look forward to working together in the future. I'd like to continue by introducing our next speaker, Dr. Ashwin Patkar from Duke University in Durham, North Carolina, who has worked extensively with the Project Lazarus. His focus will be on the lessons learned from implementing substance use disorder treatment. Dr. Patkar?
Okay. Thank you, Donnie. Good afternoon, everyone. My name is Ashwin Patkar, and I'm the Medical Director of Duke Addictions Program. I've been involved with Project Lazarus for the past 5 years. Please take a minute to review the entire Project Lazarus model. Fred Drayson has already discussed it in detail. What I would like to point out is, along with harm reduction approaches, the provision of adequate addiction treatment in the community, especially for opioid addiction, is a key safety net. And this is critical because overdose risk is higher among patients with history of addiction who are not engaged in treatment versus those who are receiving treatment. So let me give you an example. A couple of weeks ago, one of my patients who had been abstinent from opioids and taking buprenorphine naloxone called Suboxone for a while told me that he was contacted by one of his classmates over the weekend requesting that he share his Suboxone with this individual because he had relapsed to heroin. He was not in any treatment. My patient advised him to seek treatment through the local resources, and the next thing he heard was his classmate had overdosed and died. So this emphasizes the importance of engaging and retaining patients with addiction in treatment rather than a punitive approach of discharge. Next slide, please. So I'll just briefly outline my role in Project Lazarus. I have a clinical practice through Duke and have been treating patients with alcohol and drug addiction for the past 20 years. I'm a professor of psychiatry and community and family medicine and teach our medical students and residents, as well as I'm involved in federally funded research. I'm a technical expert to the Community Care of North Carolina CCNC supported chronic pain initiative termed Project Lazarus. I'm one of the presenters for the Project Lazarus program that Dr. McKeown referred to. And I'm also a regional mentor for the National Physician Clinical Support System for buprenorphine treatment. Next slide, please. Next slide, please. Next slide. In terms of Project Lazarus, the principal objective for the addiction treatment component was to improve evidence-based clinical practice for providers treating chronic pain patients with a high risk of addiction, with two important goals. One was to improve patient care and safety, and second, to ensure that providers were following state and federal guidelines regarding responsible opioid prescribing. This included providing a model CPI toolkit that Dr. McKeown has referred to, as well as training providers on screening and brief intervention, what's called SBIRT models. We facilitated registration with North Carolina's prescription monitoring program called Controlled Substance Reporting System by having the necessary forms available when we did training and encouraging everyone to be registered. The recent changes in our state law, which allow provider to delegate authority for access to the Controlled Substance Reporting System to another person in their clinical care team, has facilitated registration and use of our control reporting system. We strongly focused on increasing the number of prescribers for office-based buprenorphine, particularly in primary care practices that were managing chronic pain patients, as well as coordinating linkage between those who were providing buprenorphine and the provision of psychosocial treatment. This was a big issue with some of the providers of buprenorphine in terms of prescribing it. We also coordinated referral to opioid treatment programs called methadone programs, methadone clinics, and we also initiated a pilot project for injectable naloxone called Vivitrol to be utilized in appropriate settings in Durham. We are working with large outpatient practices to develop models of integrated care to manage depression, anxiety, and post-traumatic stress disorder. And finally, we developed a list of specialists in addiction and pain who would be willing to accept referrals, which has been an ongoing challenge in many of the rural areas in particular. Next slide, please. So when we let's go back a slide. So when we started our Project Lazarus trainings, our purpose was that it would educate those who most need it. That's the prescribers without access to CMEs in major academic centers like Duke. And what we found was somewhat opposite. Prescribers who were really our targets, particularly in rural areas, did not attend programs, while those who were really well educated in evidence-based care showed up to have discussion at our trainings. For example, one of our programs in Durham had majority of participants from Duke, while we would have really liked some of our neighboring counties to have representation. Dr. McKeown has mentioned about lack of participation from the ED doctors as well as dentists. We also had a challenge that in subsequent years, we had what I would consider audience fatigue, and we had declining attendance. And there was also some lack of enthusiasm on part of providers to implement the SBIRT model as well as prescribing naloxone. So we then modified our approaches. Our CPI coordinator, our medical director, myself, we reached out to the practices by doing site visits to make training more flexible. Dr. McKeown has already mentioned about offering CME credits. we modified the content to include case-based learnings, and this was something that the audience really appreciated. And then recently we instituted teleconferences where real cases by the providers could be discussed with specialists. In terms of screening and brief intervention, instead of providing didactic lectures, we actually had role playing with audience members serving as patients and myself or somebody else serving as a therapist. Next slide, please. So So some of the stronger challenges in terms of promoting buprenorphine treatment was to make it available to patients who had public funding. So many locations had adequate number of buprenorphine prescribers, but because of the 30 or 100 patient limit, they were either accepting fee-for-service cash-only patients or those with commercial insurance. And primary care providers were reluctant to actively prescribe buprenorphine because they did not have access to resources for providing psychosocial treatment. For example, even in a large system like Duke, we have about 5 primary care providers who prescribe buprenorphine. Some of the barriers were the stigma associated with substance use disorder patients, as well as perception of methadone as bad and addictive as heroin. So our solutions were to work with existing private or profit or not-for-profit programs who were already treating publicly funded psychiatric patients. And then we helped these psychiatrists to get certified for buprenorphine treatment. And they could then accept patients on Medicaid who had opioid addiction. We had success with this approach in Duke, but more remote areas still remain a challenge. We also worked with our managed care organization called MCOs, which is a primary portal for publicly funded patients, to get a centralized referral and appointment system. So patients seeking buprenorphine can just call a hotline and they can directly make an appointment without having to make another phone call. We are also developing co-located and reverse co-located models of integrated care so primary care providers can have psychiatric and counselor backup to prescribe buprenorphine. Next slide, please. In terms of promoting co-prescribing of naloxone, we found despite the favorable changes to the North Carolina law, we still could do better in terms of disseminating our Project Lazarus intranasal naloxone kits. And there have been a variety of factors that have to do with each link in the chain, starting from prescribers to payers to pharmacies to patients. An average cost in our network here is between $50 to $30 per kit. And in my practice, for example, what I do is I show the dummy kit to a high-risk patient and their family member and strongly recommend them buying them using an analogy of using a fire extinguisher. I've had 2 examples of patients who have reported using it successfully. One who had given hers to a family of her friend who was an active user and had overdosed at home. And second was used by a patient at a party in a dorm in a local college where a student overdosed. I think one way to increase the availability of the kits would be for the local networks to purchase the kits as well as the naloxone vials, put them together along with the educational material and make it available at local clinical offices or pharmacies. And we have been discussing this approach at one of our local federally health qualified centers. Next slide, please. So one important lesson we learned was focusing on individual practitioners alone is not sufficient, and you need to involve large health systems. And this has to do with the fact that there's a rapid change in the way the practice of medicine is happening, with major health systems playing an important role. And they actually employ several physicians rather than individual practices. So we used this approach at Duke, and we developed an opioid safety task force within the Duke health system with representatives from various disciplines. And we then had this task force make a recommendation in terms of using the control system monitoring program. And we used our electronic medical record, EPIC, as a framework for several elements of Project Lazarus. and this has been accepted by key hospital committees and very likely to be implemented. This whole process took about a year and is still ongoing, but the returns are large. So there's one last slide, which I'll then quickly focus, and then we'll wrap up. And this is the challenge of working in communities with limited resources is that urban centers, you can provide treatment, but in rural areas, it's a challenge. And to have something like Project Lazarus being successfully implemented, you need to have local approaches where you can integrate federally health qualified centers as well as health systems. And then you need to have focus on legislative level also. Thank you. That's all I have to say. I would like to invite Dr. Chris Ringwald to return to the microphone to lead the discussion.
Thanks to all of you. This has been a most stimulating set of presentations, and I have learned a lot personally. We do have some time for questions, and this is how we're going to proceed. I will read some of the questions that have shown up on the website and over the course of the last hour or so, and I will invite by name particular individuals to respond to them. I hope crisply and succinctly, so we can get through as many questions as possible. It seems now unlikely that we will get to all of them. So what we will do is to put the remainder together that we aren't able to cover, and we'll try to get responses from all of the appropriate speakers pertinent to each, and then we'll send them all out to you who are registered for this presentation. So if we don't get to your question, don't worry. We'll have it answered in a bit. So to start off, a question that says, where can I find a resource on the Dropbox implementation process? We're looking to implement a few at our local pharmacies, but cannot locate any guidance on how to navigate through this process. And this is a question for Donnie Varnell.
Yes, that's not a problem. I would give two suggestions. One of the few things that the Bureau doesn't handle is actually the placing the boxes down. DEA diversion has some recommendations and regulations they have used in the past, and their Atlanta office can be reached at area code 404-893-7186. That's 404-893-7186. And locally, I would always suggest the Department of Insurance Safe Kids. They're the ones that really ramrod the program twice a year and have the toolkits and the information online, and they can just be found at ncdoi.com, and it's the Safe Kids site on that website.
Thank you, Donnie. And the next question is for you also. You are particularly popular this afternoon. If we have so many permanent prescription Dropbox sites, is the state looking to provide support for the destruction of the pills that are taken back, since the DEA clearly cannot?
Yes, there is a child fatality task force bill/issue at the legislative level now, trying to ask for $120,000 a year of reoccurring money to support the take-back programs. The destruction costs are fairly high, and they increase every year, which of course is a drain on any set budget. So we're trying to get that done as a line item just to cover the pill take-backs.
Thank you, Donnie. The next question is for Dr. Patkar. From an inpatient perspective, can you describe some of the ways you have used the electronic records to trigger a naloxone order for patients at risk for overdose?
I would recommend an approach that any patient on an inpatient setting who has moderate to high risk for addiction, and this risk stratification can be done clinically, or there are standardized tools. They're available in our CPI toolkit. One of them is called opioid risk tool. So if they have high risk or moderate risk on these toolkits on assessment, I would use that as a sufficient indicator that they should receive naloxone.
Thank you, Dr. Patkar. The next question is for Dr. McEwen. It looks like the toolkit that's mentioned on the website is a community toolkit. Is there a clinical toolkit as well?
The ones that we listed in the presentation, those were mostly listing the tools, but there's actually a clinical algorithm in each one for in the ED and one for in primary care. Yeah, our point was just the ancillary materials, but you can find those in both of those places.
Thank you, Dr. McEwen. And the next question is for you also. How were particular audiences targeted for training and technical assistance? By invitations? How was attendance tracked? What was the outcome of trainings in terms of increased CSRS registration and use?
We did invite by invitation. Because this was a CCNC project, our primary target were primary care physicians that were working with CCNC. So we went through the CCNC behavioral health coordinator and CPI coordinator and tried to get as many physicians that way. Pfizer helped us as well because they knew a lot of people out in the field. We used the specialty groups like family practice, physicians, ASAM, the PAs, and all the behavioral health provider groups. So when we did one, we really shook the bushes and went through those groups to get the right people to attend. We also worked with the community coalitions and tried to get help from them to get the right people to the table. And then the Pain Society of the Carolinas, they were very instrumental in helping us find pain docs who could serve as mentors. We did. This question is probably more for IPRIC. One of the things that got measured was registration and use of the CSRS, but that's probably a Chris Ringwald question, and I think it's a little too early to know exactly.
That is exactly the right answer. We don't know yet, but it is certainly something in which we are highly interested in finding out. But I'm going to kick another question back to you, Dr. McEwen. What would you say are best practices to increase prescriber registration with and use of the CSRS?
Well, there's a number. Certainly mandatory use and registration and use are recommended. Our state, the advisory group, as well as the medical board, medical society, really wanted to go the voluntary route to see if we couldn't provide enough carrot and didn't need the stick. So at this point, we've tried very much to increase usage in voluntary ways. And we've made a bunch of the upgrades that would facilitate doing that. We either have or are in the process of getting the interoperability with other states, delegate accounts, unsolicited reporting. There's certainly the data sharing and research going on at the Public Health and IPRIC. Again, we have not gone the route of mandatory usage and registration, which has worked pretty well in some other states, including Florida. So it's not off the table, but at this point we haven't made that step yet.
Next question is for Tessie Castillo. Did you find resistance from law enforcement on Senate Bill 20, that is the Good Samaritan law, or was it a collaboration with law enforcement to get it passed? In other words, what kind of relationship did you form with law enforcement, and how did you overcome any issues that developed?
Mm-hmm. So for SB 20, we found law enforcement to be on board with that. I think we both have the same common interest of reducing deaths from drug overdose, and it's just a question of getting everyone to the table to agree on that common interest. With SB 154, this passed last week, I think, that was trickier. We had to come from the opposite ends of the of the spectrum on that one. But again, it was just finding what we do agree on and compromising, sort of whittling it down to what we'll be okay with.
Thank you. Next question is, Fred Drayson, for you. How are we to really change the silo attitudes, mentalities, and operational successes of those that you and many others are trying to consider for the push for collaboration to provide services to communities, families, and individuals? How do we get all these various sectors to work together effectively?
One of the major ways that we did, again, is to connect the dots for each specific group or organization that we're talking with. And of course, surrounding substance use disorder and addiction, there's many, prejudices, stigmas, myths, and all of that. So we've actually begun and are doing a considerable amount of teaching on the science of addiction so that people and individuals understand, what it is, the effects on the brain, the disease of the brain, and moving away from the moral behavioral failures to, looking at it from a disease model. And actually we're having quite success with that, with the understanding brought forward to, even law enforcement, the general community, everyone, to me benefits, from that. But there again, with each organization and each individual, the right people talking to the right people. We can't talk with everybody, but when you're talking medical talking to medical, law enforcement talking to law enforcement, people with pain talking to people with pain. If you've got those champions with the right information, the right resources and materials, they've got ears that will listen to what they have to say, and that's been our approach.
Thank you, Fred. One final question, that's all we have time for. Back to you. Do you get funding from the state, and if so, how?
Project Lazarus getting funding from the state?
Yeah.
Well, the whole statewide initiative has been done through the K.P. Reynolds Trust and the North Carolina Office of Rural Health, and all of that was funneled through the community care networks, which then again went to each of us who are participating in that statewide initiative. Other state-funded grants, community-specific, like their Strategic Prevention Framework, Partnership for Success. Those are separate, but again, play an important role, whether it be the prevention or intervention that's necessary.
My sense is that funding streams are coming from a variety of places, and some of the activities that they are sponsoring and supporting are complementary, and that we need to be alert and wise to secure support from as many places as we possibly can. And I'm reminded that some of the money is also coming from the injury branch of the Division of Public Health. With that, we are just about out of time. Let me tell you what's going to happen next. We are going to develop a white paper that will summarize what we have reported and talked about and discussed in this webinar and the first one of this two-part series. And if there are unanswered questions, we will do our best to get answers out of the most appropriate folk who have spoken to you today on this webinar. And we'll get that out to you also. So these will arrive on your inboxes, I hope, before too long. I'm imagining within a month or two. A month or two. I got a frown when I said a month. So a couple of months. And let me also say that the contact for any of you who would like to follow up on any of this is written on the final slide, the discussion slide. It's Agnieszka McCourt at unc.edu, AMCCourt, C-O-R-T, at unc.edu, and we will be responsive to you. And with that, I think we should probably close this session with a reminder, please, to evaluate the webinar. You'll see the link for the evaluation tool on the slide that you're looking at right now. So please tell us how we did and tell us how we can do better. Thank you so much for your time and attention. I'm very pleased with how all of this has turned out, and I'm gratified by your participation and response. So thank you. Bye-bye.